Now, our next session is on active surveillance. So we're going to be talking about Gleason 6. We're going to be talking about Gleason's 3+4 and see some incredible research. But the person who's doing this talk has been a longtime friend of the PCRI. His name is Dr. Laurence Klotz, and he is the professor of surgery at the University of Toronto and holds the Sunnybrook Chair for Prostate Cancer Research. He is from Canada. In fact, he's even been knighted in Canada. And when you read his bio, it says he's won some prestigious awards, but being knighted is a really big deal. He's written over 350 publications when it comes to prostate cancer, and he's a uro-oncologist. So he's done a ton of work in the field of prostate cancer, but he's also done it in the field of active surveillance, leading to giving him the title as the father of active surveillance. There have been thousands of men who have been able to go on active surveillance and forego treatment either to a later time or not even at all, thanks to this man. And he does an incredible job giving his talk as an update on active surveillance in 2024. So without further ado, here is Dr. Laurence Klotz.
Lovely to be here back in Los Angeles. I was here 5 years ago. I didn't actually realize that that was the last time it was an in-person meeting. And it's great to see a lot of familiar faces. Just before I get started, a couple of comments. I just want to completely reinforce the message that's come through this very powerful and heartwarming statements, what Dr. Heath said, what Jan Mannerite said about patient empowerment, how important this is, how it is a way to counter what at times can seem like an overwhelming edifice of medicine. So I just want to very much support that approach, which is clearly the kind of essence of PCRI. So I'm going to talk about active surveillance. I've had a lot of interest in prostate cancer, various aspects of it from kind of start to finish, but this is, I think, probably the one that had the greatest impact. Novel tools, there's Toronto looking about as good as it ever looks. Usually it's gray and overcast. The weather is not the reason to live there, but it's a beautiful city now, third largest city in North America. My disclosures, support from Exact Imaging that make the ExactView micro-ultrasound device that I'll talk about, and Mir Scientific, which I was a consultant for until they went bankrupt recently. So not too much is going to happen with that assay. This active surveillance story has really been a journey. And just seeing Mark Schultz makes me reminisce about the early days. So my group at Sunnybrook Hospital in Toronto, we had a tradition of going out for lunch about once every 6 months to try and come up with a study to do as a group. And we all knew overtreatment was a problem. We weren't sure what to do about it. It was a time when Pat Walsh, who was far and away the most famous urologist in the world at Hopkins, who came up with the nerve-sparing prostatectomy, said he thought if a patient had a positive margin, you've wasted your time and you've harmed the patient. So who has a negative margin? Grade group 1, or what was then called Gleason 6 prostate cancer. So he argued forcibly the ideal patient for surgery was Gleason 6 prostate cancer. And so we came up with this strategy of let's try watching these people. Why we came up with that is a whole other story, which I'm not going to go into, but we decided to do that. I applied for the first ever grants competition from Prostate Cancer Canada, a new research foundation. We won $35,000 grant, set up a prospective database, which was really the key to this whole thing. And then after 5 years, so now 2002, we had 250 patients, no deaths, which surprised everyone, including us, and we started to publish and talk about this. And this led to a firestorm. And the story I want to tell is, so I'm up on the podium with some giants of urology at a meeting somewhere in the United States, 500 people in the audience of prostate cancer clinicians. And I am being pummeled to death by promoting this idea of not treating patients aggressively. And these are very senior guys. I was 20 years younger, so kind of mid-career. They were very senior, world famous. And I walked off that podium feeling literally like I wanted to throw up. Like I thought, what am I doing? I'm going to destroy my career. And I walked to the back, and there is Mark Schultz. And who I didn't know. I met him once or twice. He said, Klotz, you are onto something. More power to you, do not back down. And that was huge for me at the moment, because it was really felt at times like taking on the establishment. So thanks to Mark and others, we persevered, and in fact the world changed, as I'm going to talk about. So now kind of fast forward to where we are today, and this is not a new story. It goes back 20 plus years, but there's been a lot of progress. It's still a phenomenally active area, really reflecting advances in molecular genetics and in imaging. So what's happened in the last 5 years? We know much more about the molecular genetics of grade group 1 versus higher grade cancer. 90% of grade group 1 cancer has essentially normal genomics, meaning that the tumor suppressor genes that tend to be lost in higher grade cancer are present. The oncogenes that drive cancer, that are upregulated in aggressive cancer, are normal. There's about 10% have altered genomics. Those are the kind of interesting ones, but mostly they're essentially normal. We know more about patient selection, the impact of things like age, race, family history on the likelihood that patients harbor higher grade cancer. Germline testing has become now routine for patients going on surveillance. It's cheap, it's widely available, it's commercially available for a couple of $100 now. And you can identify patients, for example, with HRR or DNA repair pathway mutations who are not good candidates for surveillance. Imaging, this is huge, and I'm going to talk about this in some data. The MRI has obviously been a game changer, micro-ultrasound, PSMA, all of them look increasingly relevant in this setting. Radiogenomics. The radiogenomics story is fascinating because essentially it turns out that, why are some cancers visible on MRI and some are invisible? And this is a genetic thing, and the genetic variations that drive MR visibility are the same genetic changes or genetic alterations that drive invasion and metastasis. So what we've learned just in the last 2 or 3 years from the radiogenomic story is that MR invisible cancers lack the molecular changes associated with cancer aggressivity, which has all kinds of clinical ramifications. Biomarkers, there's all kinds of them. How useful, still being worked out. There's new ones coming down the pipe. Predictive nomograms, I'll talk about that a bit. Modeling, which basically shows that even if over time you start to see a few patients succumbing of prostate cancer, the quality of life benefits and so on are so robust that this is not going away. Long-term outcome, the whole thing was criticized for many years. You're reporting too early. You wait. You're going to hit 15 years and all these patients are going to start dying of metastatic prostate cancer. Unequivocally has not happened. There's no kind of mortality cliff at all with long-term follow-up. We now have like 20-year follow-up on many hundreds, even thousands of patients. Follow-up strategies, increasing consensus about how to do this. I'm going to talk a little bit about some recent developments related to the tumor microenvironment and how, for example, some dietary influences and obesity influence the tumor microenvironment. And then maybe a sign of maturity of a field, you start getting these systematic reviews about every little aspect of active surveillance. So we've definitely had that. So this is a US military surveillance aircraft. What it's actually looking for is those cases of grade group 1 prostate cancer harboring higher grade disease. And you don't actually need that level of technology to manage patients on surveillance. But you can see that around the world, every group that has developed guidelines when it comes to grade group 1 prostate cancer, active surveillance is the standard of care. I will just say personally, it's been the most extraordinary journey from widespread suspicion and hostility towards this idea earlier on, which had a lot of drivers, including, of course, the financial drivers in medical practice. But I think the majority of my colleagues really felt that these patients were at risk for prostate cancer death. And once it was demonstrated clearly by multiple groups, ours and many others, that was not an issue, practice changed. So to some degree, I think the urology or the prostate cancer community more broadly deserves some credit for adopting this so wholeheartedly really against their economic interests. So now to kind of drill down into some of the specifics. So this is germline testing. Just to make a distinction for those of you who don't have a background in this area between germline testing and somatic genetic testing. So germline means every cell in your body contains the DNA for all of your genes, and you're testing, for example, the white cells or the cells from the inside of your mouth, your buccal mucosa. You're looking at the genes, see, is there a mutation, for example, in the DNA repair pathway that would drive prostate cancer. And there's a distinction here between mutations, or now the word is variant because it's less kind of pejorative. Mutations are associated with gene dysfunction and disease, things like Tay-Sachs, Huntington's chorea, which are probably these genetically inherited diseases. And then there's something called SNPs, signal nucleotide polymorphisms, which are variations in gene sequence. So for example, you have blonde hair versus brown or black hair because of SNP variations. So these are variations in the genes, for example, coding for hair color, that are not associated with diseases specifically like the mutations, but they can be associated with disease susceptibility. So that's an area of very active research at the moment. And then you have somatic genetic testing, which is testing the tumor. Like, does the tumor have mutations in the DNA repair pathway that predispose it to more rapid progression, despite the fact that the rest of the cells in the body don't? So as part of survival mechanisms in response to treatment, for example, or just over time, these cancers will develop somatic changes, and that's something else that we test for. So come back to the germline testing. So the irony about this is really a phenomenal study. Bill Catalona, the second author. Bill Catalona was world famous urologist. He's the guy who came up with PSA as a screening test for prostate cancer. First article in New England Journal describing this. Bill Catalona was the most vociferous opponent of active surveillance. He truly believed this was the worst thing for patients. He said things like, you know, Dr. Klotz, there's going to be tens of thousands of men dying of prostate cancer, and it's on your shoulders. That was something. Here he is. He turned around, he kind of smelt, heard the music, and ended up leading a large SPORE, which is a multi-group, multi-level research project, identifying genetic factors associated with upgrading in men on active surveillance. This is a phenomenal study of around 6,000 men who have germline testing, looking for SNPs, the variations that are associated with upgrading, and they found 18 new variants associated with upgrading, developed this genetic risk score. You can see the 4 different groups of the risk score on the right, showing that they really stratify for the risk of harboring higher grade cancer. So this is really coming. It's not yet commercially available, but many groups are working on this. This is another one, exactly the same idea. And you see how on the right, it stratifies patients according to their SNP profile, according to the risk of, in this case, it's prostate cancer mortality. So this is very kind of robust endpoint. And we're going to be seeing more of this. You can see this was just published a few months ago. So this field is really on fire. And now this is a series of 7 or 8 commercially available germline genetic tests. These kind of vary in quality. You can see some of the genes. So ATM, BRCA1, BRCA2, CHEK2 are all DNA repair defect genes. I'll explain a little bit about that in a minute. And then the others are well-known genes associated with with cancer progression. So you can buy these assays. They range from several hundred to a couple of $1,000s. And this is kind of an emerging field. Just for those who don't have a background in this area, this is what the DNA repair story is. So at the bottom, you see sporadic tumors in the so-called wild-type patient who doesn't have a mutation in this pathway. And essentially, you get, over a long period of time, acquired mutations. And you start with mutation P53, for example, is one of the best-known tumor suppressor genes, NKX3 and others. And then over a long period of time, you get gradual accumulation of mutations. This is called the Vogelstein model, after Vogelstein, a researcher at Hopkins. And eventually, you get a more aggressive cancer. In contrast, if you have, say, a BRCA2 mutation, it's called BRCA, because it was first described in breast cancer, but very relevant in prostate cancer. Instead of this gradual acquisition of mutations over 15 or 20 years, the cells normally have this DNA repair pathway, which is very critical to the health of the cell. So if there's a mistake in copying the genome when they divide, those mistakes are corrected, DNA repair. That pathway doesn't work, you can imagine the mistakes just accumulate. So you get this explosive acquisition, you see it there on the top, this explosive acquisition of molecular alterations, not a good recipe for successive surveillance over a long period of time. So there's a general consensus that these patients should basically be treated radically when they're diagnosed, even if they have low-grade prostate cancer. At least that's my view and many others. Not to drill down too far into this story, which gets quite complex, but there's all kinds of genes involved in this DNA repair pathway, at least about 30. You can see them there that have been described. It turns out some are more important than others. BRCA2 in prostate cancer, by far the most important. BRCA1 in breast cancer, for why it's somewhat of a difference. And in this study, it was only really 3, BRCA2, PALB2, and ATM. Names don't really matter, but those are the sort of the crucially important ones in terms of predicting metastasis. So another evolving story. And this just shows there's not much data on how these men with BRCA mutations do on surveillance. This is one small study from Hopkins. And you can see the bottom left, this is the BRCA2 patients, the red line, versus the wild type who don't have the mutation. So this is kind of earlier surveillance experience. At 10 years, about 40% of the wild type had progressed to higher grade cancer. In the BRCA2, it was almost 100%. So, these patients basically don't do too well with this strategy. So back to the usual active surveillance story. This is one recent publication from Hopkins, which was one of the first other groups to start collecting data on these patients. Almost, 1,800 plus patients. Follow-up median's 5 years, but they're followed up to 10 years. And they were very restrictive with their approach. So I don't know, it's because they were afraid of litigation. We don't have that problem to the same degree in Canada, someone being managed conservatively and then developing metastatic disease and a lawsuit. So they restricted surveillance to only the best patients, like tiny amount of grade group 1 on biopsy. And the benefit of that was the mortality rate, cause-specific mortality, 1 in 1,000 at 15 years, like as close to 0 as it could possibly be. There is essentially no doubt that 1 in 1,000 patient had metastatic disease at the time of diagnosis. Probably wouldn't have made any difference if he was treated or not. And about 1/3 of patients at 15 years were upgraded and treated. So this is kind of the best data that there is out there. This is the data from Memorial Sloan Kettering, almost 3,000 patients, mostly grade group 1, and the metastasis rate 1.5% at 15 years. So 15 times higher than the Hopkins, but still 1.5%. The vast majority of patients don't have a problem. And the other thing this shows is these two lines here, the risk of upgrading is the blue and the treatment is orange. So at Memorial, with that very low rate of metastasis, they're only treating patients who are upgraded. In other words, they didn't treat any grade group 1 patients. They were upgraded on rebiopsy. And I think that's the way it should be. One of the controversies in this area, I still hear this a lot, the patient starts with small volume grade group 1 on the biopsy, has another biopsy, now it's higher volume grade group 1. And many of my colleagues say, oh, we got to treat that patient. No, you should not be treated for grade group 1. It's a totally non-metastasized, it's not really a cancer the way people think of it. Grade group 1 disease has essentially never killed anybody in the entire world. There's a handful of anecdotal cases out of millions and millions of patients, and they were probably undergraded. This is just another series that shows kind of more contemporary outcome in the patients who were stable for the first 5 years on surveillance from Peter Carroll's group. And the message here, basically, if you look overall metastasis-free survival, 98% at 15 years. So 2% of patients metastasize. As soon as you're looking at 15-year follow-up, you're looking at the pre-MRI era, something to bear in mind. This is an update of our data. So we've gone back and looked at this database, which is now about close to 1,500 patients, 4 times. This is the most recent one. This is not yet published, but there's some very important messages here. So, overall survival, we have some of these patients followed out to almost 25 years. You follow a group long enough, the inevitable happens, and you don't end up with too many long-term survivors, unfortunately. We're still working on that, but that's a challenge. So cause-specific survival is the important one here, and it's around 4% at 20 plus years. You can see there aren't many patients out there, but around 18 years or so is when there's still a significant number of at least 100 patients, and there's a few deaths, 2 or 3%, higher than one would like. Every one of them is a personal tragedy for that individual. But here is what's exciting, I would say. We stratified, we incorporated MRI into our formal program in 2013, so 11 years ago. And then we stratified the patients to the ones from the pre-MRI to the post-MRI era. And some of you, if you're paying attention, you might say, well, how can you have 20-year follow-up if you only started doing it in 2013? And that's because some of the patients were diagnosed earlier, and then they came into the MRI protocol, started having their MRI in 2013 and later. And here's the thing, that red line, which is straight, not a single patient with metastatic disease since we incorporated MRI into this program. So what that means is that before MRI, we would be doing the biopsy, they'd have grade group 1, and we didn't know that a few of them had aggressive cancers, usually in the anterior prostate, and it was a transrectal biopsy, so it's harder to reach anteriorly, the front part of the prostate. And that's why they progressed to metastatic disease, because they had disease we didn't know about, and they weren't treated for it in a timely fashion. But since MRI came in, we find those now. We do the MRI either before or after the biopsy. Oh, there's a suspicious lesion in the anterior prostate. We biopsy that, higher grade cancer, treat the patient. 0 metastatic disease since 2013. This data to me really is like incredible validation, first of all, that imaging really works in these patients and the safety of this strategy. And then there's the issue of MR visibility. I alluded to this earlier. There's a whole pile of recent radiogenomic data, all in the last 3 or 4 years, that as I referred to earlier, shows that the molecular genetics of invisible cancers is very different from the visible cancers. They're indolent genomically. And this is a clinical validation of that. So this is a remarkable series from Sloan Kettering, 1,449 men having surgery for grade group 2 or higher cancer, what's called clinically significant cancer by most people. And they were stratified by whether the cancer was visible or invisible. So if you look at the bottom left there, prostate cancer specific mortality, the green line is the invisible cancers. Like, no one is dying of this, even if they had clinically significant cancer on their, pathologically. The brown line is equivocal MRI, and the red line is a clear cut, we call it PIRADS 4 or 5 on MRI. So strong support that invisible cancers are indolent, not just genomically, but clinically. And this is the only genetic data that I'll show. And this just shows the genetic pathways that are upregulated or downregulated in visible versus invisible cancers. And just to say, there's many of them. These are all pathways that are widely recognized by cancer biologists as being relevant to cancer aggressivity when they're altered. Intermediate risk. So this is, I think, the best recent publication on how men with intermediate risk prostate cancer do on surveillance. This is from the VA. It's like 10,000 patients, of which 1,000 of them had grade group 2 or 3. So 3/4 were grade group 2, favorable intermediate risk, and 1/4 grade group 3. And the key thing is the prostate cancer mortality at 10 years was less than 4% in the grade group 2. It's not 0, and metastasis rate about 10%. So, that's, for those guys, they likely have regret. But just to make the point, around 90% of these grade group 2 patients did not progress over a 10-year period. And so there's a huge opportunity here. Like, why are we treating 100% of these radically when only around 10% of them are really at risk? So this is where the whole biomarker and imaging thing comes in. Predicting upgrade, this is kind of a compilation of a number of papers that if you're diagnosed with grade group 1 prostate cancer, how likely are you to have something worse? Right now, as I've mentioned, I really hang my hat on the MR visibility versus invisibility. But the other ones, age, the older the patient is, the greater the chance of higher grade cancer. PSA density, the ratio of PSA to the prostate volume. Obviously, the extent of disease on biopsy. The PIRADS is the imaging. Of course, grade makes a difference, whether the patient's had a negative subsequent biopsy, and the volume of grade group 1 is a predictor of subsequently having higher grade cancer. And I just want to show, you don't need sophisticated tests to come up with quite a precise prediction on rebiopsy of how likely the patient is to have higher grade cancer. This is from the Canary Group, which is a West Coast collaboration, United States and Canada. This is widely available. You just Google Canary Pass Risk Calculator, and this takes readily available parameters: age, BMI, PSA, prostate volume, time since diagnosis, and the core ratio. How extensive was the disease on the core? And you see, without doing any fancy tests, very narrow prediction for the likelihood of upgrading. So this is the kind of thing that can be readily used. Imaging. MRI has been a major game changer. No one disputes that. Really powerful tool, but it has very significant limitations. It's not real time, so the patient goes for an MRI. I'm sure there's lots of people here who've been through this. Comes through the MRI, shows a region of interest, we call it ROI, and then is referred back to have the biopsy, and there's a complex fusion process to import the MRI image into the ultrasound, target it, lots of rooms for error with that process. The radiologist needs special training. If they've had previous treatment, there's artifact. It misses small lesions, we know that. There's a lot of claustrophobia out there. I see these big, robust guys. They just find it completely deeply anxiety-inducing to go into the MRI core. They don't want to do it. Access is an issue for sure in Canada. We have quite long waiting lists for MRIs in many regions. And this is just another issue. This is variability of interpretation. So each one of those lines is the confidence limits for interpreting the MRI across 26 centers. So you can see the predictive value of a PIRADS 4, it's out of 5. 4 and 5 are considered suspicious for cancer. 3 is equivocal. If you look at the predictive value, you want to be at this center, because if you have a PIRADS 4 or 5, you have 80% chance of significant cancer. In this center, it's 30% or 25%. So I mean, this is classic small area variation. This is not a good scenario. When you have your MRI and the radiologist says there's a lesion, is he a radiologist? Is he one of these guys or is he one of these guys? You have absolutely no way to know. So this is just another limitation of this kind of imaging. PSMA, we've heard about. This is 4 papers. You can see they're all published within the last 2 years of risk stratification and active surveillance. This, I would say, is not quite ready for prime time. It's like a $3,000 to $6,000 assay. It's not that widely available, particularly for these kind of low-risk patients. But you can see at least the preliminary data from these studies that it finds disease that was missed on MRI in almost every one of these cases. So I'm not sure about PSMA. It clearly has some benefit, but I'm not sure it's going to be worth the cost, and availability may be an issue. What is the real deal, I think, is this high-resolution micro-ultrasound. This is a recent development, maybe 4 or 5 years ago. This actually comes from my institution in Toronto, but is now diffusing all around the world. My story is that I had a research lab my whole career. I was studying prostate cancers in mice, which are very small. You either implant them, usually implanted. And I heard about a group in the research building upstairs that had developed an ultrasound microscope, so you could visualize these tiny tumors that are like less than 0.5 millimeter in diameter. With ultrasound, you didn't have to kill the animal to see how big the tumor was. So I worked with them quite a bit. I never thought this would turn into anything. You don't want an imaging device that finds a cancer that's 0.5 millimeter in diameter, because we are all developing those all the time and they disappear. It's a massive risk of overdiagnosis. But they developed this high-resolution micro-ultrasound for clinical use. It's not a microscope, but it gives almost microscopic detail. 29 megahertz compared to 6 to 9. The big difference is the resolution is 70 microns. That's 0.07 of a millimeter. And that's the diameter of a prostatic duct. And the principle of MRI is alteration in prostatic ductal anatomy, because that's what happens in cancer. That's what the pathologist sees that makes him call it cancer. And with MRI, loss of the ductal anatomy restricts water diffusion, random water diffusion by Brownian motion. So you get a signal on MRI. It's basically the same principle here. It looks like a regular ultrasound, costs around the same as a high-end ultrasound. And this just shows like the difference. So on the left, you see kind of conventional. On the right, this is with high resolution. Each one of these little green bars is 1 millimeter. So there's about 5 or 10 times magnification. And you see this pattern of these little white spots, which is the ducts. You lose that pattern, and shows this is neurovascular bundle. I mean, the detail is phenomenal. You can see here, this is a 5-year-old biopsy tract, still visible. So you can look for, if you want to biopsy the same area, you look for the track and you can put the needle in the same spot. And this shows, you can see kind of very irregularity of the capsule of the prostate and protrusion of the lesion into the rectum. Again, something you can also see on MRI, but you could never see this before with conventional ultrasound. And this shows a biopsy. So with MRI and fusion, you do the MRI. You can't see this thing on regular ultrasound. You do the MRI and you use a fusion technology to import the image into the ultrasound, and you hope it was all done right, and you have the target superimposed. With this micro-ultrasound, boom, there's the target. You would have seen this on MRI probably, and you just line it up, and boom. You have no doubt you've hit that thing. So the pathologic miss based on the co-registration of fusion targeting is not really an issue. And this is transperineal, which is the way I do it and should become the standard of care. Different topic. But again, you see the lesion, and there's really, you can be very confident you target it. So here's some of the data on this micro-ultrasound. There's now about 75 papers published in the literature. There must be 3,000 papers on MRI and prostate cancer. So this is what happens with new technology. We need more data. But this is one by me a few years ago that basically showed the sensitivity, meaning the likelihood of finding cancer if it's there, was as good as MRI. Specificity was about the same. This is from the first 11 centers that adopted this. I was lucky enough, because I'd worked with these guys, to get one of the first ones, and I really have never looked back. This compares MRI to ultrasound. In the same patient, about 60% the significant cancers were seen with both. In a quarter, only seen with ultrasound. In about 20%, only seen with MRI. So one of the interesting questions, I talked earlier about MR invisibility. Well, or visibility? What about ultrasound visibility versus invisibility? No data on this at all, but interesting question. And then this is really hot off the press. So the company wanted higher quality data, rightly so. So they've carried out this randomized trial comparing MRI to micro-ultrasound to both. So the MRI alone arm is MRI plus conventional ultrasound with fusion targeting. This study was going to go to 1,200 patients. It just closed about 3 days ago at about 700 patients because the interim analysis showed that they reached the primary endpoint. And essentially, it's a positive study. In other words, micro-ultrasound performed as well as MRI in the diagnosis of clinically significant cancer. This is going to be a very high-impact trial. I'm the PI on the study. I think this is the first group to ever hear about these results. We've just informed the investigators, which is why I think I'm empowered to actually mention this. So you're hearing it here for the first time, and what essentially, again, that micro-ultrasound, which doesn't need gadolinium, which is one-stop shopping, no MRI, and then the second biopsy, all these issues around MRI, fusion targeting, et cetera, I think this is going to end up becoming very widely utilized. Biomarkers. 9 of them or so, they're all trying to find the higher grade cancer in the patient on surveillance. They've never been compared head to head. You can see the area under the curve, which is kind of a composite of sensitivity and specificity, goes from about 0.75 to 0.90. But different populations of patients, it's hard to draw comparisons. Price between about $500 and $3,000 to $4,000 for the tissue-based assays that involve micro-dissection. It's quite labor-intensive. The question is, what's the role of these? In the average patient, grade group 1 prostate cancer, negative imaging, almost no risk of progression. If they have an image, rebiopsy. I don't think there's much role in grade group 1. We hardly ever use these in my world. Different country, it involves sending the tissue to the United States. It involves cost to the patient, which is an issue for many Canadians. So they're not much used in the grade group 1 scenario. I think they're much more widely used in the States. They do work. Like this is the GPS score. The red is upgraded, the blue is no upgrade. This is the score. You can see as the score increases, the likelihood of upgrading increases. But I don't think you need this for the average patient, and they really haven't caught on. My impression is that the vast majority of patients, certainly in the Western world, getting with grade group 1 prostate cancer don't have these assays. And I think one of the reasons for that, this is a limitation, which is tumor heterogeneity. So this is one of a number of studies that all show the same thing. This is a group of patients with multifocality. So these guys had their prostates removed, 41 patients. They had on average 4 cancers in each in their prostate. So multifocality is the rule in prostate cancer. And they asked the question, if you look at the genetic abnormalities in each one of those cancers, were they all the same or were they all different? And 90% of them were different. So the common mutations that were shared by all 4 on average cancers is the orange, but all these other mutations were unique. So you do the biopsy, you find grade group 1 prostate cancer, you stamp your Visa card, pay the $4,000, send the slides down to California for the Oncotype DX assay, and it tells you what the gene alterations are of that tumor, but they're not shared in 90% of cases by the other tumors in the same prostate. So it's kind of a conceptual limitation of the tissue-based assays. Another thing that is coming, AI, I mean, what else is new? Whatever field you're in, this is having an impact. But there's a company based in California that's using AI to analyze the slides. So they're not doing any additional stains or testing. They're just training the AI, the machine learning, to scan these slides and identify very subtle abnormalities associated with subsequent risk of progression. So this is definitely coming. This is almost certainly going to work. This is cheap. Like, you're basically paying for a computer a scanning of these slides. It's going to be hundreds of dollars, not thousands. And this may really kind of move the needle, I think. Another aspect of this whole story is de-intensification. So for example, you have a 60-year-old, he has 1 core grade group 1 prostate cancer. You follow him for 10 years, nothing happens. No change in his PSA. He has a rebiopsy or 2, nothing more than grade group 1 disease. Does this guy still need to be followed with repeat imaging and repeat biopsy? Probably not. And there's definitely a move to kind of de-intensify the good ones, up-intensify the higher risk patients rather than one one size fits all. And obviously, as patients get older, they move from the regular surveillance, which is nowadays serial imaging plus minus biopsy, to the old term watchful waiting, meaning just basically PSA and take some action if there's dramatic change in PSA. And we do that when the patient kind of hits their dotage, however you want to define that. Age around 80 plus or minus, keeping in mind their other health issues and so on. And then finally, innocuous interventions. So this is something I've been interested in. I know Mark is like a world leader in this area. I'll be interested to hear what he has to say. You have a patient sitting in front of you. So look, men do not like going to the doctors. Men tend to neglect their health. This is a lot of data on this. But boy, and again, I'm preaching to the choir here. I realize you folks have more personal experience with this than I do. You're sitting in front of the doctor and he tells you you have prostate cancer, you're paying attention. And so the doctors have the opportunity to intervene in a favorable way to have far more benefit on the patient's health than anything you do for their prostate cancer. And so I kind of divide this into 2 groups. There's the motherhood recommendations. So number 1, stop smoking. There's data on this. If you're a specialist, you have a patient newly diagnosed with a serious illness, and you spend 2 minutes counseling him to stop smoking, that has a durable effect on smoking behavior. We don't do this. And there's also data, the greater the proportion of patients in a country who smoke, the less likely the medical profession is to intervene. Probably because the doctors are some of the smokers. But so, this to me is like a no-brainer. This needs to become incorporated into clinical practice in urology, radiation oncology, et cetera. Dietary modification, again, everybody knows this. Reduce obesity, moderate red meat intake, increase fruits and vegetables. Regular exercise, if it were a drug, we would all take it. 8 different ways that regular exercise has been shown to improve the tumor microenvironment in prostate cancer, improves hormonal profile, growth factors, epigenetic modulation, all kinds of things. It's good for you. And there's one study now, this is a Canadian study, of high-intensity interval training in men on active surveillance. So it was a pilot study, only 52 men randomized. The other half of patients got basically said, yeah, you should exercise, but the HIIT group got exercise, got trainers and phone calls and so on. And with a prostate cancer endpoint, PSA went down, PSA kinetics improved, and as everybody knows, cardiovascular fitness got better, mental anxiety, fatigue improved. So I think now you have at least some data, it's only a pilot study, to really recommend this to patients on surveillance if they're not doing it already. Obesity. This is something that's really fascinating at the moment. So obesity is not good for prostate cancer. This is one study, the likelihood of progression and mortality according to BMI, and there's a pretty clear-cut relationship. But we've only learned recently why this is. So this is really, to me, fascinating study, New England Journal a couple of years ago, obesity in the tumor microenvironment. It's very counterintuitive. It turns out in obese men, the cancer cells become ultra acquisitive of essential free fatty acids, lipids basically, fat, the fat molecules, some of which are essential for normal cellular metabolism. And the result is that the immune cells, which act to keep the tumor under control, are starved of these essential free fatty acids, and this results in impaired tumor immunity. And impaired tumor immunity results in a higher rate of progression. The kind of mechanistic aspects of this and some of the molecules involved in turning on this switch to make the cancer cells so greedy has been worked out. So this is why patients who are obese have a worse outcome with prostate cancer at almost every single stage. Obesity best avoided, and if possible, to be reduced in patients who have it. This is one study that just shows the amount of periprostatic fat around the prostate is associated with a worse prognosis if there's a lot more fat. So it's kind of the same concept. Should patients drastically alter their diet when they've been diagnosed? I hear this from patients all the time. They'll come and say, annual follow-up, they'll say, yeah, I went on a vegetarian diet and I'm exercising constantly and I'm taking, the following long list of micronutrients, and it's amazing, my PSA went from 7 to 6.2. And I say, more power to you, but I'm a little skeptical. As far as the data, this trial is the best we have, led by Kelly Parsons, who I think is here at UCLA. Almost 500 patients on active surveillance, randomized between switch to a vegetarian diet with nutritionists and instructional all kinds of intervention to really get them to change versus a pamphlet. And it was a 2-year endpoint. And, diet and health are closely linked. I think certainly every health practitioner knows that. Unfortunately, in this population of patients with a 2-year time frame, it was a totally negative trial. It made no difference to PSA, to biopsy, anything. Why? maybe it doesn't really matter at that point. It matters over your life, but once you're middle age, 60, 65, maybe it's too late. Maybe 2 years is not enough. Certainly to modify diet to reduce or avoid obesity is worthwhile. Beyond that, I just tell patients eat a healthy diet. And then finally, this is getting even more controversial. It's, a lot of type A men, they hear they're diagnosed with something potentially serious, and the passivity of surveillance does not sit well with them. They want to do something. So I hear this a lot. Doctor, there's got to be something I can do to slow this thing down. So I give them 3 pieces of advice. Vitamin D, this is not relevant in Los Angeles, but it's very relevant in Toronto, northern climate. Vitamin D deficiency is ubiquitous in older people in my part of the world. I suspect less so here. But there's definite data showing that prostate cancer mortality closely associated with low levels of vitamin D in this collection of 7 papers or so. Not everybody buys this, but vitamin D costs around 5 cents a day, 1,000 international units, plus if they take a multivite, they get another 400. And I believe it's completely harmless. And given this kind of data, I think it's warranted in populations where there's not a lot of sun exposure. By the way, just to give you an idea of the dose, if you go outside in Los Angeles in a bathing suit and lie under the sun for 3 or 4 hours, you get around 10,000 units of vitamin D generated. So 1,000 is really not that much. Statins. Again, there's a whole story. You could have a whole lecture on this topic. Statins are a prostate cancer drug. Statins interfere with what's called the mevalonate pathway, that downstream of that pathway, you get all kinds of mitogenic molecules that stimulate proliferation of cancer cells, insulin-like growth factor, and so on. That's the basic research. And then at a clinical level, no randomized trials, but clinical level, here is results from 3 or 4 studies that essentially everyone shows the same thing. The prostate cancer mortality significantly reduced in men on statins compared to those who are not on statins. Lots of confounders in this kind of data. Maybe the guys who are on statins are more health conscious, et cetera. I mean, a lot of reasons why it may not be real, but you have preclinical data supporting it, and you have these kind of registry studies that also support it. And then finally, metformin. I know, like Mark Moyad is also last time I checked, I hope maybe I'm wrong now, big metformin fan. This drug really looks like a health promotion drug. And what it does is it induces metabolic stress in cells. And it's very healthy for cells to be in a state of metabolic stress, because what it does is it causes them to switch from a proliferation pathway to a repair pathway. And there is really fascinating data, not so much in humans, but in animal and preclinical data, that switch to a repair pathway by the cells in your body prolongs health of the cells and prevents cellular senescence or aging. So metformin is one of the things that has been shown to do that. Other things like exercise, caloric restriction, and so on as well. But, so metformin looks like a health promotion drug. And in the prostate cancer area, again, up until about 3 weeks ago, no randomized trials. I'm going to get to that. This is the cohort studies, meaning they've looked at here 1.6 million men, mostly diabetics, some on metformin, some not, and all the way through better overall survival, better cause-specific survival, et cetera, lower metastasis rate, lower prostate cancer mortality rate. So, this to me looks very, very compelling. Reported at ASCO in June, this Canadian study called the MASS trial. I was a participant. Metformin versus placebo in men on active surveillance. The study, not published yet, 407 men, very low risk, so only 1 or 2 positive cores, which is the first problem. 1,700 milligrams per day of metformin, biopsies at 18 and 36 months. I was 100% sure, as sure as I could be, this was going to be a negative trial. And I don't know, sometimes it's nice to have your preconceptions confirmed. It was a negative trial. In fact, there was no signal at all that the metformin was working. The patients who had a high BMI, for reasons that aren't clear, did worse with metformin. I suspect it's got something to do with this metformin interacting with these impaired immune cells. So this hadn't been published yet. I'm not quite sure what to make about this. I do think the problem is that they were looking at such a low-risk group that the rate of upgrading was relatively low. It didn't take into account MR imaging, and I think maybe just 3 years is not long enough to see much effect, but there you go. So you can't really make a compelling evidence-based case for metformin at the moment. I haven't stopped advising patients about this, though. And then finally, I'm wrapping it up. What's happened in the United States? The blue line is uptake of surveillance over the last 15 years or so, still rising, still a ways to go. You can see like 50 to 60% of eligible patients getting surveillance. The other 40%, or at least most of them, should still be offered surveillance. It's really unfortunate that they're not. We still do the confirmatory biopsy, but imaging is increasingly replacing this. It doesn't have to be done within a year. You can wait for 2 or 3 years if the patient prefers. PSA every 6 months. DRE, I used to do 40 DREs in an average clinic. Now I do 1 or 2 digital rectal exams. Digital rectal exam in the era of imaging has very little value. We do germline testing routinely. We do MRI every 2 to 3 years, alternating in my practice with micro-ultrasound. I think that's going to become increasingly widespread. Fewer and fewer biopsies. Image-guided management. Imaging is negative. Patient probably doesn't need a biopsy. Intervene only for grade progression. Think about other health measures that I mentioned. And increasingly, we're going to get AI, and these liquid biomarkers are, I think, further going to refine this strategy. Thank you very much.
So the DRE is, you don't do digital rectal exams anymore? Because the reason I'm saying this is I just have my colonoscopy, and even the colonoscopy docs give you a DRE. So I just want to know what you think about it.
Well, they're doing it probably because they're looking for colon cancers, for rectal cancers. Look, I've been teaching medical students for 35 years. You know, as part of the physical exam, you have to do it. You have to get over your kind of aesthetic reservations about it.
Yeah.
But the reality is, at least for prostate cancer, it adds very little.
Okay.
Yeah.
But do you still do it?
I do it once in a while.
Okay.
I do it if the patient's referred to me because there's a suspected nodule. But I know I'm going to be imaging this patient.
Okay.
The patients who have a palpable nodule that you don't see on imaging, I almost never, that's like 1 in 1,000 or less.
It would have been nice if you mentioned that 3 years ago, that we didn't need it as much.
You mean for you personally?
For me personally.
Yeah, I figured.
And what scares me about you is you have very big hands.
You are not the first one to complain about that, I can tell you.
Okay. Can you bring up my first slide for Dr. Klotz? That's me curling. What do you think of my curling skills? Do you say they're adequate? Because you're in Canada, everybody curls, plays hockey, and drinks beer.
Hockey, I'm a hockey player. I could definitely comment. I mean, you don't look good as a hockey player there, I'll tell you that.
Okay.
And I don't think you look great as a curler either, I have to say.
All right.
But, you know, you never know.
Yeah, you should be just commenting on prostate cancer at this point. All right. I brought this up with you a year or two ago, and I want to see where you stand on it, because I am completely opinionated at this point on this. Bring up the next slide. I'm just quoting papers that you've been on and other people that are big wigs in the field. And here's one of the quotes. Of all the common cancers, prostate cancer has the highest genetic contribution to risk or highest heritability. So there's this old perception that genetics and prostate cancer might be a relationship, and now all these researchers are suggesting that of all the cancers, some of the largest genetic contribution might come like in a family history, so prostate is very tied genetically. Why isn't every man on active surveillance getting a genetic study to make sure they don't have BRCA1 or 2? Because that would mean that cancer may be more aggressive. Why isn't every man who's diagnosed with active surveillance getting a genetic test automatically? Why is it the minority?
I don't know why. We do it. First of all, just keep in mind, you're talking about 5%, roughly, maybe at the most 10% of these active surveillance. If you look at the whole population, it's about 5%.
Yeah.
If you look at patients with that Dr. Heath was talking about with advanced prostate cancer, it's more like 20%. There's obviously a selection for patients with the mutation. So, you're looking for 5% signal. And, there's some cost, and it's kind of moving its way into the medical culture. But this whole area of kind of risk profiling is not the usual mindset of physicians who are used to sort of seeing a patient with a disease. So I think it should become routine, but
Thank you.
Yeah.
So, the impact study?
Yeah.
Okay, so let me explain this study. This study is just kind of looking at men who may be higher genetic risk, and what they came out, correct me if I'm wrong, I haven't seen the latest data, they found that the majority of men that end up with these genetic mutations, BRCA2, the majority of them, when they were questioned, had no family history of prostate cancer. Yet they're coming up with this genetic mutation that shows that they probably have a very serious prostate cancer. So asking about family history is like throwing darts. At some kind of board. I'm saying it's important, but I would think you'd want to be more accurate than just asking about family history and just do the test.
No argument.
Okay.
Family history is a clue, right?
Yes.
And it's not just prostate, it's breast, ovarian, et cetera. But family history is important. But yeah, there are these sporadic cases.
Okay. Do you remember in 2003 and 4, someone came to your office and said, why aren't we doing a cholesterol-lowering study in prostate cancer? And you said, let's do it. And do you remember now it's 2024? And do you remember who that person was, and now you regret that you didn't do that study? Do you remember who came into your office in 2003? Would you like to? It's not Trudeau.
I was going to say, I actually did meet Trudeau around that era. Maybe it was him. This is a bit of an inside joke. Dr. Moyad and I have been talking about this for 15 or 20 years.
Yeah.
And yeah, your point is well taken.
I'm not trying to show you up. I'm just saying that now I know you're a big fan, but I don't think it's just about me and you. I think it's embarrassing that we haven't done just globally such a study when we knew in 2002, 2003 that heart healthy was prostate healthy. And so hopefully somebody does it. But I think maybe you and I still have a chance. We're older, but we could still get this done, right? So anyway, I just had to throw that in for therapy.
Can I just ask, how many men here are taking a statin? So that's one of the problems. To find a large cohort of men on active surveillance who aren't taking it and then randomize them, that was one of the difficulties. We weren't sure how feasible it would be because it's become such a widespread, so widely used.
No, that's a good point. It's tough. I asked you to look at your active surveillance cohort. You went about 6 months ago and said that over 3 out of every 4 men were taking a statin, right? So that's difficult. But you don't want to hear my counter argument, do you?
Not really.
Okay. My counter argument is this is why it's so important to keep up with the education. The amount of research coming through the pipeline is exponentially greater every year than the year before. We have these drugs now called PCSK9 inhibitors. They're injectables. You can drop cholesterol down to a 9, a 15. They're unbelievable. 10 years from now, when they become cheap, they'll completely wipe out the statin business, or at least make it go quiet. You can get a cholesterol down in these guys at much more aggressive levels and reduce their heart disease risk and then see what happens much more than a statin. So I think this is coming. And I apologize that if all someone does is go on a statin and it doesn't change their prostate cancer, it just reduces their #1 risk of dying in men in general, which is heart disease. It's like, okay, that's not a bad side effect, right? By the way, the #1, you've had the longest active surveillance protocol and series in the world. What is the top cause of death in the men on active surveillance that you have followed? What's your update?
Cardiovascular disease.
Cardiovascular disease.
Sure.
Dominates?
It's like 40%.
So it's their number one risk of dying is cardiovascular disease. All right.
You knew that.
No, but I didn't know. I know you keep updating the numbers. You know, you think something else would catch up. But I didn't know it was still number one. It's, you know, so, okay. All right. I have a really funny question for you because this is, I've never asked you this. This just kind of dogs us in breast cancer. In breast cancer, there's a group of people that actually think that some of these non-aggressive tumors, when they do follow-up mammographies and other studies, they can't find them. So there's a contingency of people that think there's actually some cancers that spontaneously regress.
For sure.
Wait, I haven't asked you the question yet. So do you think some men on active surveillance that have a tumor, that tumor could spontaneously go away because of an immune response or a statin or something like that? I've never heard your opinion on that. You say for sure?
For sure, the phenomenon of spontaneous regression of cancer is a very real phenomenon that hasn't received much attention. But in breast cancer, there's data that women are developing these tiny breast cancers all the time, and that when they're tiny, 90% of them regress spontaneously. And for whatever reason, a few of them, don't regress and continue to grow. So cellular immortality is not a trivial thing. Like for a cell to be immortalized as a cancer cell and keep growing and growing and growing, there's all kinds of molecular mechanisms that have to be present, and not all cells have it. They need to attract, for example, angiogenesis. So you have a tumor, lacks the mechanisms to induce new blood vessels to allow it to grow, and it dies. And this is the kind of thing that goes on all the time. We have no data in prostate cancer, but I'm sure it's a phenomenon. That's why a considerable proportion of patients start with minimal disease.
Yeah.
You rebiopsy, negative, negative, negative. We say, well, it's just small volume disease. We're missing it, but maybe it disappeared.
Wow. All right, I like that. Because you hear, we talk about it in breast cancer all the time. It just doesn't get enough attention. Can we go?
Agree.
Okay, we're going to finish off with some stuff you didn't know I was going to tell you about. I saw your name on this paper. And basically what this is taking active surveillance. Now, I don't want you to comment yet. You take active surveillance, and correct me, it's an offshoot of flutamides, right? So are you injecting this in the prostate? So you're injecting hormone therapy in the prostate of active surveillance patients, and you're getting a response. But don't comment yet. Next slide. So, okay. So I'm thinking of changing the name of active surveillance to active surveillance with treatment. And the reason why is everybody's telling me that these patients aren't supposed to be treated, but let's go over what's going on in clinical trials right now. There's the stuff you're injecting in patients' prostates that's hormone therapy, and you were getting good results. That's kind of cool. There's dietary and exercise trials. There's focal therapies. There's an immune therapy with Provens that's just finished, I think. We're waiting on the results. Those are active surveillance patients. They're using the prostate BPH pills. We can talk about that. Repurposed drugs. Go to my next slide before we come back. I want to show you. There's one more.
Enzalutamide.
That's
that the one you're going to show?
No. I'm going to show you. Go to my next slide, please. Those are all these focal therapies going on right now, including one that you do called Tulsa Pro. So now go back again, and I want him to comment on these. So if nobody's being treated on active surveillance, I didn't get that memo. Look at all these people getting treatments in these clinical trials. So walk us through. You already walked us through the diet stuff and exercise, but walk us through these other treatments and where you think we are.
Look, the trial you showed, this was a pilot study, really proof of principle. Could we do this safely? Inject a drug that we thought might cause some regression. The active surveillance cohort made sense because these patients weren't getting any other treatment. So, I'm not never, and the results were lousy, by the way, but I'm never going to suggest that would be something that should become, a standard of care. It's just focal therapy, not for grade group 1.
Okay.
The only caveat is, I made the comment that invisible cancers lack aggressive genetic alterations. The other side of that coin is you get once in a while these guys, PIRADS 5 on the MRI, like they really have a nasty looking lesion. You biopsy it, grade group 1. You biopsy it again, it's still grade group 1. No matter how many times you keep going back, grade group 1, but highly visible. We don't know whether those guys actually have more aggressive cancers. So, there's kind of an intellectual argument that maybe those patients should get some kind of focal therapy.
Okay. Well, what about the focal?
But otherwise, I'm against treating. Focal therapy is not for grade group.
But what about the focal therapy that you helped invent? I mean, the Tulsa, right? The Tulsa Pro.
So in the pivotal registration trial,
yeah,
I led it. We had about 25% of the patients were grade group 1.
Okay.
None of them were mine. But around the world, there are people who advocate for focal therapy for grade group 1. These guys with large volume disease, young patients. We were very anxious to get accrual to this trial. This was a new technology, and it's not that easy to get patients to agree to that, so that was the kind of compromise.
Did you eliminate their tumors, or not?
In 85%, yes.
For how many years out?
5. We have 5-year follow-up. Let me just quickly, I don't believe in the 5 ARIs, finasteride, dutasteride, too many side effects, loss of libido.
Yeah.
The data on this, there's a lot of it. It reduces the volume of grade group 1 cancer, but it doesn't have any other favorable effects. Has no downside, so it's useful as a BPH pill, but not for the prostate cancer. And one other thing, this ENACT trial published by Neil Shore.
That's the anti-androgen? Yeah.
That's the anti-androgen.
At the top. So you're talking about with the pills?
Oh, yeah.
Yeah,
enzalutamide monotherapy.
Yeah.
These men get very substantial gynecomastia.
Yes.
It has a lot of side effects. It makes no sense whatsoever, but it was a positive trial. It reduced basically the volume of grade group 1 cancer, which is of no clinical value.
Okay, so you're not excited about that.
I think it's...
Okay, so you and I have talked privately about metformin is kind of interesting to me. Just for a reminder, every time people get gaga about the drug, in 2002, metformin in cardiovascular medicine went up against exercise and diet and lost. Exercise and diet actually had better results than metformin in reducing the risk of getting type 2 diabetes. So I just want to keep that in perspective. However, you and I talked about these new weight loss drugs. I mean, those have profound changes in cardiovascular health potentially. How are you excited about these new Ozempic and all these other commercials?
They're like Metformin Plus.
Yeah.
And I mean, I believe that there are trials now just underway of these Ozempic type drugs with a prostate cancer endpoint. And I mean, again, the MASS trial I showed was negative. Yeah. These are more powerful drugs. Better trial design, who knows?
Okay, so there's your comment on that. My last 2 comments before we let you go is, can you tell people what systematic biopsies are and why you're not excited? I mean, you said now we have MRI. What it actually is a systematic biopsy, and how's that different from other types of biopsies?
So this whole field is evolving, but the initial transrectal ultrasound came in about, 40 years ago. Really kind of just when I was in training, and it was called sextant biopsies. You couldn't see the cancer, you could see the prostate. So 6 biopsies done randomly through the prostate. Then after about 10 years, it became apparent 6 wasn't enough. They were missing the cancers. Again, these were called systematic, but basically blind. So the number increased to 12. The standard of care for the last probably 15 years, maybe more, 12 systematic cores distributed through the prostate. This was done transrectally. That's 12 times a needle is going, from poop into the sterile prostate. Roughly 3 to 4% of men would get very serious acute prostatitis or urinary tract infections from this. There was also a mortality rate from that, which is somewhere around 1 in 2,000. It varies, but you're taking basically completely healthy guys who have an elevated PSA and you're putting them at risk. So first of all, there's been a switch to transperineal biopsy, which in my opinion is long overdue. It's a much better way to do it. And then now we have imaging before biopsy. So that's a shift that occurred maybe 4 years ago. MRI or micro-ultrasound, you have a target, you put a needle in the target. Where the controversy is, if you're doing that, do you still need to do the 12 cores through the normal-looking part of the prostate? It's still done widely. That's the standard of care. The MRI is negative. Most patients are still getting the systematic biopsy. Based on what I said, and it's a longer story, I think that should change. There's the systematic biopsy should go the way of the dodo bird, with very few exceptions. You get some very high-risk patients who have negative imaging, but you can almost smell the prostate cancer. And, they're the outliers, like very high PSA density, family history, all kinds of risk factors, but negative imaging. I do systematic biopsies in those, but with the exception of those rare patients, targeted biopsy, modified a little bit, and following the patient if they're negative is the future.
There's a lot of men that it seems in my world, that when we talk to around the world, they'll get a biopsy, and they'll have a high PSA. The biopsy shows nothing, or the biopsy shows a low Gleason grade, so they're on active surveillance, but they never got an MRI at all. The biopsy determined their outcome. Do you think, because now listening to you, it makes me think that nobody should start on this pathway and get a biopsy that's negative or positive without also, after the biopsy, doing an MRI to make sure there's nothing else there that's being missed?
No, the standard of care increasingly is imaging before biopsy.
That's the standard of care, but let me tell you, it's not
happening. Imaging before the biopsy, have it after the biopsy. You got to wait 3 months.
That's fine.
That's done. I think that's caught on.
I don't know. I'm just saying that when you're in Toronto, you'd be surprised. I mean, a lot of people still don't get MRIs or even told about the power of MRIs. So I just want to know what you thought about that. Okay, that doesn't get you out of my last request before we go to lunch. So a couple of years ago, people didn't realize I had to attend a couple of meetings with him, and he gets up and he starts playing the piano, and I thought, where is this talent from? How does this guy have this time to develop this talent? He's pretty good. So he came up and played. So we actually brought the keyboard here, and I thought, I'm going to make this harder. The keyboard I kind of lied to him. I said the keyboard is for entertainment for tonight. They needed to have it here. It was a great lie. It really fell for it. So we know who you like. We like a couple musicians. So the PCRI staff, we decided we're going to give you a random song to play, but it's going to be one of, I know, your top 3 favorites. And then maybe we can call it for lunch after that. Now, keep in mind what his day job is. All right, so here it is. Ready? Oh. I actually know this song. So this is Elton John, which you are a big fan of. I know one of your top, and it's the song called Your Song. He wrote that song. It's a very a philosophical song. So there's no pressure here.
No pressure.
I mean, it would be nice if you entertain the audience before we go to lunch. So if you say no, I'll say too bad. Thank you.
It's a little bit funny, feeling inside. If I was I'm not one of those who can usually hide. Don't have much money, but if I did, my big house where we both would live. If I was a sculptor, but then again, no. Or a man who went around to meetings talking about prostate cancer. I know I'm not much, but it's the best I can do. PCRI is the greatest conference I've ever seen. And you can tell everybody this is your song. It may be quite simple, but now that it's done, I hope you don't mind. I hope you don't mind that I put down in words how wonderful life is with PCR in our world.
was good. That was good.
Not my best version. All right.
That was really good. But before I give you your gift, I'm feeling a little jealous because I think you're very talented. But when you combine yourself with me on some kind of project, you're extremely talented. So I think...
I'm hoping that's something edible.
I think we should do something together.
All right.
Because we can send people off to lunch, but do we have his gifts up here? So just before you start, hold on a second. Hold on a second, because I want to make sure we send people to lunch appropriately. All right, so here, I just want to give you these before, because I want your musical talent to shine at the end. So we bought you a cup that has a hockey puck going through it. It's a glass. We thought that you would like that, the hockey theme. See, that's good. You like it?
Yeah.
Did anyone ever give you one of those?
No.
Yeah, exactly. That's why we're here. We're here for the big budget items. All right, the second thing we gave you was a cup. I want you to put in your office. It says, I don't need therapy. I just need to play the piano. All right?
Ready?
I'm ready.
You say tomato.
And I say tomato.
You say tomato.
And I say tomato.
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 Tomato. Let's call the whole thing off.
You say tomato.
And I say lycopene.
You say tomato.
And I say lycopene.
Tomato.
Lycopene.
Tomato.
Lycopene.
Let's
call the whole thing off.
You say tomato.
And I say fiber.
You say tomato.
And I say fiber.
Tomato.
Fiber.
Tomato.
Fiber.
Let's call
the whole thing off.
You say tomato.
And we say it's lunchtime at the PCRI.
You say tomato.
And we say it's lunchtime at the PCRI.
Tomato.
Lunchtime at the PCRI.
Tomato.
Lunchtime at the PCRI.
Let's call
the whole thing off. It's lunchtime at the PCRI.